Good evening, everyone. So I'll go on to my presentation where I'll be talking about approach to diagnosis in BBD. Now, most children who have BBD present with all of these symptoms. But the last line is very important, and that's when most of us as urologists probably see them. Otherwise, generally, they usually go to the pediatricians, and then the pediatrician has to refer them to us. So remember, UTI and pain abdomen in a child getting referred by the pediatrician, you should have BBD as one of your top diagnoses as of now. We all know the different types of voiding dysfunction, but what we are going to talk about today is the combined bladder and bowel dysfunction, earlier called as DES, dysfunctional elimination syndrome, now called as BBD. Now, this is from Dr. Shripathi's paper. How do you recognize? You have two components. You have dysfunctional voiding and you have constipation. You combine both, you get BBD. But if you have any of the three of the six parameters, a thick wall bladder, trabeculated bladder on the MCU, a large bladder, and of course, spinning top deformity, clinically demonstrated Vincent's curtsy or any of those positions that these kids take, and infrequent voiding, with or without the evidence of constipation, you should strongly consider BBD. There are many tests. I will be running through a few of them, but when you do repeat uroflowmetries, you do get a staccato pattern. Now, how important is dysfunctional to get a routine MRI in dysfunctional voiding? Most of us who are here are specialists, subspecialists dealing with children who are already having complex problems. And most of them, please remember, we are usually the second or third doctor that these kids are seeing. So if you have significant upper tract changes, if certain things are suggestive of a probable neurogenic cause, don't hesitate to get an MRI, at least from the practice of the children that we see, though the yield is 7.5%. Please remember that we cannot miss, because if we miss, then it becomes a big problem. And look at this interesting statistic from a paper way back in 2000 and 2001. But I guess in India, we're going to see more of this as we go forward. This is another very good statement. I think all of you would agree with this. Over the last decade, at least, bowel dysfunction as an important cause. Slowly, the importance has actually come out. And it is usually associated with children with all these conditions. And constipation or bowel dysfunction, they can present with encopresis, abdominal pain, UTIs, and because of very hard stools, some of them may have fissure in anus, and you have to do an inspection before you attempt a rectal exam. And infrequent bowel movement. Please remember that they don't come to you with a history of constipation. They usually come to you with the history of UTI or pain abdomen, whatever, upper tract changes, etc., etc. And we need to elicit that history, because for many years, this child has been continuing to pass stools like that. So that is actually normal for the child and for the parents or caregivers. So therefore, you need to ask a lot of leading questions. When you are examining when you're doing a physical exam, check for soiled innerwear, and of course, an X-ray, etc. And you can use this simple Bristol stool scale, which you can have in your outpatient. And this also gives you some sort of a prognostication factor when they come back to see how much they have actually improved. One more point, you'll be surprised that most of these kids who are between 4 to 8, the parents have never gone and seen the potty, how the stool's consistency looks. So give a printout of this chart and tell them to go and compare, because these kids generally go to the toilet by themselves and they flush it. So nobody knows. So these are all difficult things to elicit, and you'll have to give them time. And when they come back to you for the next consult, probably they'll tell you better. Now, constipation in our definition, for us who are dealing with BBD, involves all of this. It is just not saying that, the child passes stools once in 2 days. It could be any of these or a combination of all of this. And these, of course, is the principles of bowel management, which I won't go into very much detail. But why constipation is so important, we are all aware. It results in UTI or may result from UTI, both ways. And again, this corollary, very important. And next question that you can ask is, how long does the child spend on the toilet, on the potty? Again, you will find that a 7-year-old child, 8-year-old child spends 30 seconds, 1 minute on the potty, and then they come running out because something more interesting is happening outside. So when you train them for management of constipation, you also need to tell them to spend sufficient time on the potty. I have some more slides. Again, this is very much related to BBD, and over a period of time, Dr. Venkatesh is here. He's very much interested in everything that deals with plants. And we have the CFTRI, the Central Food and Technology Research Institute in Mysore. So a lot of Indian food, the amount of dietary fiber in the content of the Indian food was not identified. So we got into this, and this is some of all of this. So when you actually counsel the parents and the children on what is the amount of total dietary fiber, that is TDF is total dietary fiber per gram of all of that, just go through these values, and then you will find that which are the type of food that has more dietary fiber, which you can actually advise to the parents or children. So the pulses have the maximum amount of TDF. These are the leafy vegetables. It's a common thought process that they would probably have, not as much, except for curry leaves. And roots and tubers are actually the lowest in the TDF. Wide principle is anything that is grown under the ground, the dietary fiber is usually less. And this is some other vegetables. Again, this is all Indian food, which all of us have day in and day out. And these are in fruits. So the maximum TDF that you actually have is in pulses. And these are all poor in fiber vegetables, because a very important aspect of handling constipation is the diet. Very important. So get your dietary team and dietitians and all of them to understand all of this. And this is very poor in fiber fruits. Right? So there are a lot of misconceptions in all of this, which I think we need to clarify. This is again a very favorite slide of mine. Most children develop dysfunctional voiding, bowel bladder dysfunction, and all of that due to these modern distractions. They don't pass urine on a timely basis because there is so much going on the computer, on the mobile, on the screen, and online classes during COVID has made it worse. They don't want to go to the toilet between a TV program because they miss something, etc., etc. So these are all things that you'll need to correct. You ask, I have started asking the screen time that the children actually spend. Today, at least in Bangalore, a 6 or 8-year-old child spends around 3.5 to 4 hours of screen time per day. This is after school. So this is a serious problem, and we need to understand that all of what we deal may emanate from somewhere else. Now, how do you check for objective improvement in dysfunctional voiding? You look at all these things because it's a combination of everything. There is no 1 + 1 = 2 or doesn't fit exactly into one particular investigation. So you could look at all these things as you follow up the patient. And this, of course, is for management of constipation, which we are all aware of. One of the important things is to correct the posture and pelvic floor relaxation. It wasn't very important when the Indian toilets were being used, or if the child is actually squatting and passing, it's okay majority of the time. But when you're using the Western toilet, you will need to make sure that all of this is there. You can see that the child has a stool and the legs are placed on the stool. And also that red device, which is under the gluteal region, is the adapter. So I will show you some pictures now because this is for BBD. You have multiple pictures, but just concentrate only on the urethra. So these are normal MCUs. Just concentrate only on the urethra. Both these are all in kids, male and female. These are all normal MCUs, and those markers, we place those lead markers at the external urethral meatus by putting a plaster. And most of the children, we do suprapubic MCUs by a needle technique after giving local anesthetic ointment to the suprapubic region in all toilet trained children. So this helps us to avoid the urethral catheterization and makes the entire experience much more better. I'm just showing you all normal MCUs. This is just to emphasize how abnormal VCUGs can be there, and the fact that dysfunctional voiding and the classical spinning top deformity of the urethra and everything might not be there in every patient, but you will find a spectrum. You'll definitely find a spectrum, and then you'll just need to very closely look at the urethra. These are all our patients over a long period of time, which we've been collecting. And then I have matched it to the uroflowmetry. Again, the classical staccato pattern, what you see in textbooks, may or may not be there. You will have some variation of that. This is bowel loading, very easily picked up on an X-ray. And these are the different type of uroflowmetries that you can actually see. This is pre and post treatment. All of these are dysfunctional voiders. So you may or may not have the classical staccato pattern, but you will have it somewhere there. So before I wind up, it's almost impossible for us to do this by ourselves. I think all of us are busy clinicians in the outpatient or wherever. It is preferable that we develop a urology specialist nursing team who will be able to assist us in this entire pathway of training the children, urotherapy, biofeedback, the dietary support, food habits, enemas, bladder diary, etc., etc. Thank you very much.